Sorry. I'm sorry. Jesus.
We'll start in just a second.
That was me. Everybody's audio good? Sorry.
Again, good evening. My name is Matthew Davis. I'm the County Public Information Officer. Thank you for coming this evening. It's my pleasure to introduce to you Dr. Bela Matias, the County Public Health Officer.
Good afternoon, everyone. I'm Bela Matias, County Health Officer for Solano County. I want to begin by letting all of you know that the CDC has confirmed that a Solano County resident has been identified with coronavirus with no known exposure to a coronavirus positive individual and with no travel history. The implications of that being that this person appears to be a community acquired case of coronavirus, which would be the first here in the United States, but it is worth noting that community acquired coronavirus has been an issue under discussion in multiple countries, for quite some time already. It's also worth noting that most respiratory diseases that we experience come with a range of symptoms, from asymptomatic to very severe, and it's very unusual for a respiratory disease not to have some element of transmission from people that are either not showing symptoms or showing very mild symptoms. So this type of spread is not at all unusual and is something that we've been expecting and that we've been planning for. We do want to nonetheless reassure our community members that the health risk for acquiring coronavirus here in Solano County remains very, very low. The disease has been evolving since it was first described. This has been a very dynamic and rapidly changing disease that we've been dealing with. We have also, in order to allow us to investigate this incident more effectively and more efficiently, have declared a local public health emergency here in the county. And with regard to the individual in question, this patient, we don't know what their exposure was. So at this point, we don't know where the patient was exposed. We know that the patient became ill, was hospitalized at a local hospital in our county. The patient was hospitalized in our county at a local hospital, became progressively more ill, was transferred to UC Davis in Sacramento. At some point, the patient became ill enough to warrant testing for coronavirus, and the result came back positive. It is, again, worth noting that the patient wasn't tested prior to that because they weren't severely ill enough and they had no connection to any of the known risk factors for coronavirus. And so it represents a scenario that while we knew we would ultimately have to deal with, we were nonetheless not able to be able to predict for that individual. It's also very important to note that this individual is not a repatriated evacuee at Travis. We have had multiple plane loads of evacuees at Travis Air Force Base, and this individual has no connection whatsoever to that federal mission and to any of the personnel that have been involved in that evacuation process. So this does appear to be a person who genuinely did acquire their illness in the community. Because the patient did not initially meet the criteria for coronavirus testing, the patient was not in airborne isolation at North Bay or at UC Davis initially, which means that there were multiple healthcare personnel who were exposed to the individual. At both hospitals, we are at present aggressively evaluating everyone who may have had contact with this patient. They are being identified and their risk for exposure is being assessed, and they are being put into categories that are appropriate. Some of them are under isolation, some of them will be under quarantine, some of them represent too low a level of risk to warrant either of those types of approaches. But the hospitals are working aggressively to identify and properly address the individuals in those environments. Solano Public Health is working very, very closely with our state partners and with CDC. CDPH has generously agreed to provide us whatever support we need, as has CDC. We were also fortunate that there were already CDC personnel at Travis dealing with that other mission, so we've had immediate access to the assistance that we've needed. And we really do want to call out kudos to the HHS, aspirin CDC personnel, as well as the U.S. Marshals, as well as Travis Air Force personnel for that repatriation effort and for the work that they've done with us, as well as to Travis Public Health for their assistance as well. In addition, we're working with all of our neighboring counties because the personnel who work at North Bay, the personnel who work at UC Davis, live in multiple counties. And so we need to work with our partner counties to make sure that all of those individuals can be appropriately quarantined and home isolated with the assistance of whoever is most appropriate for that individual. At this point here in Solano County, we're transitioning from trying to contain the disease to more of a mitigation approach. We recognize that if we do have community spread, that it becomes necessary to consider more aggressive protection of our critical resources, hospitals and other healthcare facilities. And so we have recommended that they adopt a more aggressive prevention stance toward individuals who don't meet the coronavirus risk conditions, but are nonetheless community-acquired respiratory disease. We've set up our Departmental Operations Center so that we can coordinate our efforts more efficiently. As I said, we've invited assistance from the CDPH and from the folks at CDC. The county is prepared to manage the situation. I will say that it was actually probably rather fortuitous that we were a county that was asked to assist with the repatriation effort, because our hospitals and our personnel and our local public health officials have been very aware and very comfortable in dealing with coronavirus for quite a while now. And so when this occurred, it was, we were able to just step up and do what was necessary to address the problem as efficiently as possible. And for that, we really want to genuinely thank our healthcare partners who have done a tremendous job in carrying the load, the lion's share of the load in dealing with those issues. I want to remind people that coronavirus, as far as we know, and by all indications, is spread in a manner very similar to influenza. And so the precautions that we've been advising people about for many months now to protect ourselves against influenza are completely appropriate for the protection of individuals against coronavirus as well. The droplets are the way that it spreads, so if you are sick, we ask that you stay home. If you are coughing or sneezing, cough into your sleeve, cough into a tissue, not onto your hands. Wash your hands frequently with soap and water. Wash them for a long enough duration to actually clean your hands. If soap and water aren't available, use an appropriate antibacterial, antiviral, antiseptic. And so the ability for us as a community to address this exists. We already do this. We do it every flu season, every respiratory disease season, and we simply want to make sure that we remind ourselves of the things that we need to do in order to stay healthy. And then, as I say, for the healthcare environments themselves, we want to make sure that the healthcare personnel take the necessary droplet and contact precautions for people who come in with respiratory illnesses, and continue to do airborne isolation for those that are considered to be at risk of having coronavirus. And the last point we want to make from our perspective is we want to remind individuals that this virus does not discriminate. There is no race ethnic component to this disease. The cases of disease we've had run across all ages, spectrum, both genders, all races and ethnicities. And it's very, very important not to be blaming victims in this situation. And with that in mind, I think that we can weather this just as we've weathered other similar events in the past. With that, I'd like to introduce Steve Huddleston from North Bay Medical.
Thank you, Dr. Matias. Good afternoon, all. I have only a few brief comments to make. I think I've spoken to most of you already today, at least once. And I don't have much to add to the statement that was released earlier today from our hospital president, Amy Brewer. If those of you who haven't seen or had a copy of our statement, I have some available to you if you wish to chat with me after.
Sir, is there any way to just keep the papers further from the microphone?
Thank you.
Thank you, sorry.
I do want to emphasize and clarify some of the reporting that's out there. Both of our hospitals are open, operating safely, and accepting patients in our emergency departments and our clinics throughout the community. We continue to deliver the kind of care that people have come to expect of us over our 60-year history here in Solano County. For a few hours last night and in the early morning hours, we did ask the EMS administrators to redirect some ambulance traffic to neighboring hospitals while we adjusted our staffing after some of our employees were taken off their work schedules and sent home to monitor their situation and their current health. We continue to check and double-check to ensure that we've identified every employee who has come into contact with the patient, no matter how briefly, after the diagnosis. As far as the head count is concerned, at this time, I can say it's a moving target. We have identified dozens of our employees on our health team, but it still remains less than 100. I want to also ask, implore you to consider the patient privacy. I know you're doing your best to report on all facets of this story. Some of our employees, however, are being contacted as they leave work, somehow contacted through their private emails and their cell phones, and please respect their right to privacy as well. Finally, again, I will add that we're pleased to be able to work with our partners in County Public Health, the State Department of Public Health, and our other neighboring hospitals, as well as the experts from the Centers for Disease Control. Again, if you need to see our full prepared statement, I have copies for you afterwards. Thank you.
Next, I'd like to introduce, for brief remarks, just to introduce the CDPH is the acting state epidemiologist, James Watt.
Good afternoon. Thank you very much. I don't have any prepared comments, but I did want to say that I am here representing a team of technical experts who are here to support efforts by Solano County to respond to this event. And Dr. Matias outlined a number of steps that are being taken, and we are actively working with them to get those things done and get them done quickly.
Appreciate it. And then finally, I wanted to introduce Christopher Braden representing the CDC. Is it Colonel yet? Sorry, Captain.
Yeah. Thank you very much, Dr. Matias. Yes, my name is Chris Braden. I'm from the Centers for Disease Control and Prevention. I flew in from Atlanta, Georgia this morning. I'm here at the invitation of the county and the state, also to provide technical expertise to the various investigations that are going to be going on around this case, and in these hospitals where we know that the patient has been cared for. So that's our role. We're going to be basically embedding within the teams that are going to be doing these investigations, both on the part of the state and the part of the counties actually involved, multiple counties. Thank you.
I guess it's time for questions.
Doctor, is it possible that this is more than just a coincidence that this first U.S. case of communicable contraction of this virus came in the same area where this Travis Air Force Base mission was?
You know, I think it's probably more of a coincidence, not in the sense that the evacuees had anything to do with it, as much as it is that our providers are just way more aware and astute because of it. You know, I would offer to you that there are probably cases of coronavirus from community acquisition in multiple parts of the country right now, and they didn't necessarily have the experience to know what to look for. So I would go the other way with that, and I would say we see it as a blessing that we had the opportunity to prepare.
Can you give the layman's version of switching from containment to mitigation?
Yeah, so containment, thank you, it's an excellent question. So containment represents the goal of preventing the disease from entering into your space at all. You try to keep it controlled in a location where it starts and bottle it up so it can't go anywhere. And that's only possible when you're dealing with a disease condition where you know everyone who's sick and they get sick before they spread and you can contain them. And that's a rare reality. Mitigation is, we know that the cat's out of the bag in terms of it having spread, and what we're trying to do is slow the spread as much as possible. The slower that it spreads, the more time we have to identify treatments that can help, the more time we have to consider the possibility of a vaccine and other types of measures to protect. So mitigation is extremely important in slowing the spread of a disease, but it's also a recognition that it's not staying in Wuhan, and we already know that. There are multiple outbreaks throughout the world.
Doctor, how long will those healthcare workers be
Quarantined or isolated?
Self-quarantined, and could those numbers rise significantly further than the dozens?
No, the numbers won't rise beyond the numbers that have already been identified because everybody has been evaluated. We're still in the process of, but we know who all the healthcare providers were that could have been in that environment. So that's been very thorough. And they started as soon as we were aware of this case and worked through the night. And we have a very good handle on that, so the numbers won't rise. And the length of time for isolation and quarantine, so isolation is if you already have symptoms. And we're testing everybody with symptoms to see if they have those symptoms from coronavirus. If they come back negative, we still assume that they could develop coronavirus in the 14-day incubation period. So 14 days from last exposure to the patient. Now, the good news is that for many of those healthcare workers, we're already 7 days in, because people that only saw the patient in the emergency room, for example, did not see the patient on the floor. And then that patient wasn't in our county for a number of days before diagnosis was made. The patient had already been transferred to UC Davis. And so our personnel only need to be in there for 14 days from the time of last exposure.
And when was she last here?
I'm sorry, what?
When was she last in Solano County?
I want to say 3 or 4 days ago. What was
The
it?
19th.
The 19th. Oh, more than that.
Morning of the 19th.
Morning of the 19th was the date of transfer.
Doctor, there's a whistleblower complaint.
I'm sorry?
There's a whistleblower complaint that federal health workers were freely moving in and out of Travis Air Force Base during the quarantine and possibly, without training or protective gear. Is there concern there? And I would also like Mr. Braden to answer if possible.
Well, so I don't have anything to say about a whistleblower complaint. What I can say is that we've been working with our federal partners on the base since they first arrived, and I have actually never worked with a more meticulous group of people. I mean, they were scary meticulous, and so the likelihood that would happen is low to begin with. But it would also have no explanation whatsoever for this patient, because this is a random individual in a community of 450,000 people. Chris, did you want to add anything to that?
Answer the question as a member of the CDC.
So yes, we are aware of a whistleblower complaint, and what I would say is that, as we have said many times, this is a rapidly evolving situation, and we learn more and more all the time. And the situation actually on March Air Reserve Base, where that complaint was lodged, was quite different, and we know that there was no either evacuees with coronavirus in that group, nor was there any transmission around them. So those are the things that we can say. And I'd just like to say, again, repeating here for Travis Air Force Base, that there's no indication that any of the evacuees, even when having coronavirus disease, would have crossed paths with this case that we're discussing today.
So, I'm curious, it's clear that this person did not meet the criteria, correct?
Initially.
Initially. So is that criteria now changing? Like, are you retiring that to now test people who may not have even come in contact with this person?
So there's a couple of questions in there. Yes, the criteria are changing. I think Chris is probably best able to answer that. As for what we can and can't test, there are two problems. One, what are the criteria? And two, what are the number of people that they need testing relative to the ability to test? I mean, we're still dealing with a test that is limited in its availability, so we still have to prioritize by risk, and we're not going to be prioritizing maybes over likelies.
Why is it so limited in its availability? I mean, there's other countries that have this test
that I
widely
honestly
available.
can't answer. Do you want to try?
So first thing about the testing and testing of this particular individual, like I said, rapidly evolving situation. And just when you talk about testing, it's not just a healthcare provider and CDC. There's a number of people that are involved in that decision making. There's the people at the hospital, of course, and the providers, also local health department staff get involved in making those decisions and determinations about who should be tested, who may not need to be tested. State health department may become involved, and then eventually we have a consultation line that's open 24/7 that takes those consultations to determine who should be tested.
This case took 4 days for someone to make a decision.
Yeah, so what I can say is that there were multiple people involved in the decision over those four days. It wasn't necessarily CDC. And the other thing is there was a change in the approach about who we test during that period of time. so that the people with more severe disease met the definition of those who would require testing. And that change in that kind of policy did take place during that time, period of time.
Did you say it's rationing the way you're treating the test?
Could you talk about how you're investigating the female patient and who she came in contact with and how you're going about that?
Let me also amplify a little bit about what Chris was suggesting. Patients like the one who ended up being positive are huge in number in our hospitals. This was a needle in a haystack. And so there's no way to determine that it would be that versus anybody else like that. And that jump in number of people to test, we're just not prepared to do. But the likelihood is still incredibly low compared to the people with exposure to known cases, people who have traveled from China. So the cases among them are far higher in proportion, so we still have to prioritize them until there are more resources. As for what we're doing in the investigation, we have identified family members of this individual, and they are in isolation pending testing. They'll remain in quarantine for this 14 days since last exposure to the patient. The patient's workplace has been fully addressed as well, and we are identifying any potential interactions with people that are not employees in the workplace during the time that the person was infectious. The good news in the community is that the individual is really only potentially infectious for about a 3-day window before hospitalization occurred. And so we have a narrow enough window to work with that we can be very aggressive in identifying all of the possible contacts in the community. And those are individuals who will be assessed and will be isolated or quarantined as appropriate.
There are some people that want to know where this victim was.
There's a lot of people wanting a lot of details about the victim that I cannot divulge. What I can tell you is good news and bad news. Bad news I can't tell you. Good news, it doesn't matter that I can't tell you, because if it's community acquired, the risk is not at the location.
There was some pushback and back and forth between the state and CDC today on how quickly the CDC knew. I think there's a statement only on Sunday. Can you get into that at all as far as whether the testing was appropriate and whether it should have been handled more quickly?
You want to try?
So the consultation came to us on Sunday, the 23rd, to determine whether the patient should be tested.
Sir, do you think Congress or the White House has been slow in reacting with funding for this? You got a president who said that April, it was all going to go because it's going to be warmer. They're just now talking about extra funding to handle this. Have they been slow in Washington?
Well, so a couple of answers to that. Number one is that, we do this type of work day in and day out. And so a lot of what we get in our annual appropriations funds this type of work. Now, given that this is a much bigger type of circumstance, like we had with H1N1 flu or with SARS or, for that matter, Ebola, so forth, you do need supplemental funds in order to be able to handle that. Now, exactly how much funding we're going to be able to need or how much we actually do need is a bit difficult to determine at this point. But I trust the Congress to come up with a funding amount that will at least make us able to not only support ourselves but the states in what they need to do.
But you do need many more test
In his
kits,
press
correct?
conference this morning, he mentioned test kits will increase exponentially.
Yeah.
But also left, they kind of closed with the issue of the mask. California has a million masks.
Well, let me just, this is the third time I've been asked about the tests, and let me just address this a bit. So, number one is the test has actually been developed very quickly in many countries around the world with just what was some public data from the sequence of the virus that was put out by China early on. And so we are actually around the world able to test much faster than we have in the past with the technologies that we have today. Now, we have been frustrated in getting out a test widely that's being able to, that was manufactured at CDC because we're very, very careful about the quality assurance of that test, and some of the laboratories have seen some issues with quality assurance that we're addressing. Now, in addition to that, we would really like to see some commercial tests come out to be able to provide that to public health laboratories and to hospital laboratories. And I believe that commercial entities are working with the FDA to make that happen as soon as possible.
So can you clarify, everybody that came into contact with this new patient, healthcare workers, family, coworkers, what are they being asked to do? And all those three groups combined, what is that number at? How many people?
So they're all being asked, depending on whether they have symptoms or no symptoms. If they have symptoms, we are testing them and asking them to home isolate while we await results. If they have no symptoms, we are asking them to home quarantine. We are interacting with every one of those individuals multiple times daily to make sure that their needs are met, to make sure that they aren't developing signs or symptoms of the disease. So there is an ongoing active surveillance of that group of people. As for the total number, because we don't yet know how all of the North Bay health professionals are going to end up on this, it's under 100, and it involves multiple counties.
Can I ask you, Doctor, because you don't know how, maybe you addressed this earlier, I don't think so, because you don't know how this person was exposed and acquired it, how do you go about, other than what you just described with the people who you do know came into contact with this person, how do you go about, now that the cat's out of the bag, mitigating the spread when you don't know where they got it?
So that's an excellent question. The thing about this disease is it's too early to know what path it's going to take in its natural course. SARS came on with a bang and then went away. MERS has existed in its location and occasionally jumps out and causes international spread, but then retreats to its location. H1N1 came out with a bang and was the predominant flu strain for many years. So we can't know today what picture we're going to deal with. What we do know is that if we can remind our community to practice proper droplet precautions, as they should be anyway for flu, that will slow the spread and will optimally protect people from spreading to others. Now, obviously, that's very difficult in families. I mean, interactions within families pretty much guarantee that there will be intra-family spread if this disease becomes more widespread. Our hope is to prevent outbreaks in healthcare institutions, in schools, in congregate facilities. Our goal is to have it be a low level of disease in our background, where most cases are mild and don't require hospitalization, and delay it enough so that those who are severe enough to need hospitalization will have something that we can offer them in the way of treatment.
What's the difference between home isolation and home quarantine, and is there a legal mandate behind either of those?
So the difference between isolation and quarantine is that when a person has symptoms, we isolate them. We isolate them in a much more rigorous way than when we quarantine people who don't have symptoms, because we're waiting for the results to come back on that person with the symptoms as to whether or not they have this disease or don't. So quarantine can, for example, permit people within a family to interact on a limited basis, wearing proper PPE, for example, but isolation would not. Isolation is just a much more strict level of containing a person we're worried about and keeping them away from others. And so the answer really has to do with the what else do we do with it, and it's the testing that's the most important. With quarantine, we're waiting to see if symptoms emerge, so we check on you frequently. With symptomatic disease, we're worried that you might get sick enough to need hospitalization, so we're prepared to do transport, et cetera. So it's a somewhat more aggressive stance that we have to take.
You touched on this earlier, that this case of community spread is a coincidence that it's in this county.
One sec, I'm sorry.
Are there any legal penalties? We see
Oh.
Sheriff's Department members here.
I can issue isolation and quarantine orders. You probably have no reason to know this, but we deal with this issue all the time with tuberculosis, with measles, with chickenpox. I mean, there's a lot of disease conditions where we have to isolate and quarantine people. So our ability to do it is very well practiced. I mean, we do it with great frequency. It is very, very rare that people are not compliant, because the risk to themselves, to their families, to others is recognized by most people as being genuine. So yes, we have the authority if we need it, and we rarely have to exercise